Okay, let's dive right in. So picture this. You're prepping the room, maybe getting that scope ready for a GI endoscopy. Today we're doing a really important practical deep dive. It's all about the stomach specifically, the
Right.
essential stuff that you, as an endoscopy nurse or tech, really need to know. Like have it right there.
That's exactly right. Yeah, and it's not just like textbook anatomy, right?
Yeah.
Not just physiology. This is really foundational stuff. It directly translates into how well you can anticipate things.
Yeah.
Understand what the endoscopist is seeing on the screen, make sense of those reports later, and just, really be part of providing great patient care.
Exactly. And our guide for this deep dive is coming straight from just a fantastic source. It's Dr. G.S. Raju's video, 2025 ASGE Endoscopy Tech Course B Stomach.
Hmm.
Really informative. It's just packed with those need-to-know details. And actually, quick thanks to Google NoteBookLM, too, for helping us sort of pull out the key points from it.
Yeah, it's a great resource. Really focuses on what's practical, what matters in the procedure room.
Absolutely. So our mission here, it's basically to unpack the stomach's key anatomy, how it's systematically looked at during the scope, the common things you might actually see in there. Some crucial procedures like targeted biopsies and important patient management points too. All from this expert source. I'm actually really excited to get into these details, the stuff that makes a difference right there in the room.
And understanding the why, the
Yeah.
why behind these technical bits like the source lays out, it really takes your role beyond just technical support. You become like a really knowledgeable part of the team.
Okay, so let's unpack it. Let's start with the absolute basics, the anatomy. Just like the source describes it, step by step. You come down the esophagus, boom, entry point to the stomach. That's the gastroesophageal junction, right? The
Yeah.
GG.
That's the inlet.
Yeah.
And right below that first section you hit, that's the cardia.
Cardia, got it. And then get sort of up to the left, that dome part,
That's the fundus, often kind of tucked away.
right? And then coming down from there, you're in the main part, the long section.
Yeah, the body. And visually, you'll notice in the body those big long folds running down the walls, pretty parallel.
And those folds, they're not just for show, are they?
Yeah.
The source points out that's where really critical stuff happens, like making acid and pepsin.
Exactly. That's the engine room for digestion in a way. Then as you move down the body, heading towards the outlet, you reach this distinct bend, like a ridge. That's the incisura. Think of it as a landmark,
Okay, the incisura. And that separates the body from the next big area.
right? From the antrum.
Ah, the antrum. That's the grinder, isn't it?
Yeah.
Where all the mechanical work gets done, breaking down food.
Precisely. That's its main job. And then the final exit door.
The one leading out to the duodenum?
That's the pylorus, the outlet.
Okay. And we also have those two main edges, the curvatures,
The lesser curvature, that's on the patient's right side.
and the greater curvature on the left. So let's recap that map. GEJ inlet, cardia, fundus dome, the long body with folds and acid, the incisura bend, antrum grinder, pylorus outlet, and the two curvatures. But okay, let's get practical. Why is it so crucial for you, the tech or nurse, in the middle of a busy procedure to have this map locked in your head?
Well, because the endoscopist, they're constantly talking in this language, right? When they're dictating findings or saying where they're taking a biopsy, they'll say something like, okay, finding on the lesser curve of the antrum or taking a biopsy from the incisura. If you know this anatomy cold, you instantly know exactly where they are.
Right, you can picture it.
Yeah, you can see it on the screen, confirm it, and maybe anticipate what they need next or, just accurately document where that sample came from. It makes you a way more effective partner.
It really does. It connects what they're saying to what you're seeing.
Yeah.
Okay, map acquired. Now let's talk about the actual journey. How the endoscopist explores this anatomy, like the source details. It's not just wandering around, is it?
No, no, definitely not. It's actually quite methodical. That's what's interesting. They start by entering, and they sort of park the scope right there at the GE junction. And from that spot, they look down, get a really good view of the cardia.
Okay, so start at the top, then move down through the body.
Exactly. And the source breaks it down nicely. They examine the upper third, notice those strong parallel folds, then move down to the middle third where the folds are still prominent, and then the lower third where you start seeing the folds kind of taper off as you get near the antrum.
And they'll spend some time looking around the antrum itself, checking all sides.
Definitely. Then they'll usually move in closer, get a good look at the pylorus, that opening, sometimes peek right through it.
Okay. And then comes the tricky part, right? the retroflex.
Oh, yeah. Yes, the visual acrobatics. They pull the scope back a bit into the antrum, usually, and then they bend the tip way back on itself so it's looking up towards where they just came from.
Wow. So from that flipped around view, you can see that incisura ridge really clearly, can't you?
Super clearly, it stands out. And by rotating the scope while it's retroflexed, they get a great look at the fundus, the upper part of the lesser curve near the cardia, the upper greater curve.
And often, by just adjusting a bit, they can see pretty much the whole stomach, again, from that angle. Check the rest of the greater curve, the body walls.
It's a really important view for catching things you might miss on the way down. Then finally, they'll straighten the scope back out, get one last look at the pylorus, maybe take another peek, and then gently push through into the first part of the duodenum, just for a quick look around there too.
So understanding that sequence, GEJ, down the body, antrum, pylorus, the whole retroflex maneuver, then straightening out, duodenum peak. How does knowing that help you as part of the team?
Oh, anticipation, huge. Knowing the routine means you can almost like read the endoscopist's mind.
Yeah.
You know when they're likely about to retroflex, so you're ready. Maybe you need to adjust suction or just understand why the view suddenly flipped. You can guess when they might need, say, water to clear the view, or when they might ask for the biopsy forceps because they just saw something in the antrum. It just makes everything smoother, more efficient.
It really does. Turns what looks like random movement into something predictable.
Exactly, a systematic survey.
Okay, so we've navigated the stomach systematically. Now, what are you actually likely to see in there? Let's talk about common findings the source mentions.
Well, surprisingly often the stomach might look pretty normal, maybe just a little bit irritated, some redness.
And the source is really clear, isn't it, about two main culprits if you do see irritation or specific findings.
Oh, yeah, big ones. NSAID, use, ibuprofen, Motrin, aspirin, that sort of thing. And the other big one, Helicobacter pylori infection, H. pylori.
Which really highlights why asking about those meds beforehand is so important, right? Before the scope even goes in.
Absolutely crucial history, yeah. Beyond just general irritation, you might see what the source calls erosions.
Erosions, okay. What do they look like?
Think red streaks, often with yellowish lines kind of running down the middle.
Okay. And the key thing about erosions, according to the source, is they're breaks in the lining, but they're shallow.
Exactly. They don't go all the way through the muscularis mucosa layer. That's the defining feature.
Right. Because if the break is deeper, if it does go through that layer,
then we call it an ulcer. That's a deeper defect.
Got it. So erosions are shallow, ulcers are deep.
Right. And whenever you see either one erosions or ulcers, the source gives you this mental checklist instantly.
Okay, what's on it?
Think H. pylori. Think NSAIDs. And always, always consider, could this be cancer? Need to rule that out.
Makes sense. In cancer, it often looks quite different, doesn't it? Based on the source description.
Yeah, it can. The stomach might not stretch out well with air. It might seem kind of contracted, stiff. The folds might look really thick, distorted, maybe nodular. You could see really large ulcers or just ugly-looking ones.
And the source pointed out something else specific. Sometimes you see areas where the folds are just missing.
Yes, where they should be, but the lining looks flat, pale, thin. That's gastric atrophy.
Gastric atrophy. And that's a serious sign.
It is, because it means those specialized cells, the ones making acid and pepsin, they've wasted away in that area. And the source mainly links that to either, long-term H. pylori damage or sometimes autoimmune gastritis.
Okay, this leads us perfectly into a really key procedure, biopsies. Especially when you see these kinds of findings, or sometimes even if you don't, depending on the patient's history. And specifically, the source emphasizes the Sydney protocol for mapping those biopsies.
Yes, the Sydney protocol. It's really important because just taking a random biopsy isn't nearly as helpful. The pathologist needs to know exactly where in the stomach that little piece of tissue came from. It changes the interpretation.
Okay, so how does this mapping work? The Sydney protocol. Sounds pretty specific in the source material.
Oh, it is. Very specific. It's a strategy. You take typically 2 to 4 biopsies from the antrum. Remember, that's the grinding section down near the outlet. And those pieces, they go into their own separate jar, jar A, clearly labeled.
Antrum samples, jar A.
Then you specifically aim for the incisura, that bend, that ridge between the body and antrum. Biopsies from right there go into their own jar. Jar B, also clearly labeled.
Jar B for incisura. So we're already separating samples from areas that are pretty close together.
Exactly. Precision matters here. Then you move up into the body of the stomach. You take, say, 2 or 3 biopsies from the lesser curve side of the body. Those go into jar C.
Lesser curve, body, jar C.
And finally, you take biopsies from the opposite side, the greater curve of the body, and those go into jar D.
Okay, wow. So it's antrum A, incisura B, body lesser curve C, body greater curve D. 4 specific jars, 4 specific locations. Why? Why go to all that trouble? What's the actual purpose of mapping it out like this?
And this is where the source gives us that really crucial insight. It's not just about being fussy. This precise mapping lets the pathologist figure out the distribution and the extent of any problem they find, like gastritis or atrophy or that other change called intestinal metaplasia.
Okay.
Is it just happening down in the antrum, or has it already spread up to the incisura? Is it affecting the whole body on both sides?
And why does knowing the spread of, say, atrophy or intestinal metaplasia matter so much? What's the significance?
Because, and the source really stresses this, the bigger the area that's affected by atrophy and intestinal metaplasia, the higher that patient's long-term risk is for developing gastric cancer.
Wow.
So the care you take in getting those biopsies into the right, specifically labeled jars, A, B, C, D, that directly helps assess that patient's future cancer risk.
It's a technical step, yeah, but with huge clinical meaning. That really drives it home. How a seemingly small detail, like labeling jar B correctly, connects directly to, potentially, a major patient outcome down the line. The source does mention, I think, a simpler 2-jar option sometimes used, like antrum incisura together and body curves together.
Yeah, that's sometimes done maybe for cost reasons or simplicity. Antrum plus incisura in one, lesser plus greater curve in the other. But the source definitely reinforces that the full 4-jar A, B, C, D Sydney protocol gives the most detailed map.
More information for the pathologist, better risk assessment.
Exactly.
Okay, let's switch gears a bit to patient management. The source touches on handling some urgent situations you might run into. Let's talk bleeding first. What might you see, and what's the absolute priority?
Right, bleeding, you could see, old dark blood looks like coffee grounds sometimes, or bright red fresh blood, maybe big clots filling the stomach, and the source is like crystal clear on this.
Yeah.
You need to be ready for suction instantly. Good suction is critical.
And patient safety, obviously paramount. What's the main risk there?
Aspiration, breathing that blood into the lungs, it's really dangerous.
So what does the source recommend?
Keep the patient's head up, if possible. And definitely, in serious bleeding, strongly consider having anesthesia intubate the patient. Protect that airway.
Right. Secure the airway first. And then, looking for the source of the bleed, what could it be?
Could be lots of things. An ulcer that's actively squirting blood. Or maybe you see a blood vessel in an ulcer base that's not bleeding now but looks like it could go any second. Could be a clot just sitting on top of an ulcer. Or specific conditions like gastric intravascular ectasia, GABE. That's often called watermelon stomach because it looks like red stripes.
Ah, watermelon stomach, okay.
Could be varices too, those swollen veins, usually from liver disease. You can get them in the main stomach or big ones up in the fundus. And unfortunately, cancer can bleed too. That's always on the list.
Okay. What about another tricky situation? A patient who's actively vomiting, especially if they weren't NPO and there's food coming up.
Yeah, that's another really high-risk one. Again, the big danger is aspiration. Maybe even higher risk than with just blood.
So what's the advice from the source there?
It's pretty direct. It's usually better, safer to get anesthesia involved right away. Intubate the patient first, protect the airway before you try to scope. Trying to navigate a scope through a stomach full of food and vomit is just asking for trouble.
Makes total sense.
Yeah.
Safety first. Once the airway is safe, what might the endoscopist be looking for as the cause of the vomiting?
Well, you look for some kind of blockage, an obstruction, often right at the exit, the pylorus, or maybe just beyond it in the first part of the duodenum. A narrowing, called stenosis, can stop the stomach from emptying properly.
So a physical blockage.
Could be. Or it might be that the stomach muscle itself just isn't working right. It's weak, doesn't contract properly. That's what we call a weak stomach. Or, clinically, gastroparesis.
Gastroparesis. That leads nicely into the final piece from the source. A quick but really interesting look at how the stomach normally works after you eat. It goes through phases, doesn't it?
It does, yeah. It's a pretty cool coordinated process. Phase one is called accommodation.
Accommodation. What happens then?
So when food first hits the stomach, the upper parts, the fundus and the body, they don't start churning right away. They actually relax and stretch. They expand to make room, comfortably hold the meal until you start feeling full. Satiety.
Okay, so it's like a temporary storage tank first. Then phase two must be.
Grinding. Phase two is grinding. Once you stop eating, the stomach's built-in pacemaker kicks in, starts muscle activity. The antrum, mostly, and the lower body start these strong contractions to really grind the food down into tiny, tiny
Right,
particles.
like a biological blender.
Yeah.
And only after it's ground down. Phase three.
Phase three, emptying. Exactly. That exit valve, the pylorus, it mostly stays shut until the food particles are small enough. Then it opens up, just briefly, intermittently, to let the ground-up stuff empty slowly into the duodenum.
And how fast should that happen normally?
The source says in a, normal, healthy person, more than 90% of the meal should be gone from the stomach within about 4 hours.
And if it's much slower than that?
Then, like we just talked about, that's basically gastroparesis. The stomach isn't grinding effectively or emptying properly. It's delayed.
And the source even mentions how they test for that, right?
Yeah, the gastric emptying study, it's pretty neat.
Yep.
The patient eats a standard meal. Often they mention like a radio-labeled Big Mac or eggs, something with a tiny, safe bit of radioactive tracer mixed in. Then, over a few hours, a special camera or counter tracks how quickly that radioactivity leaves the stomach. It directly measures how well it's emptying.
Fascinating. So much practical, useful stuff packed into that one source video. We really covered a lot. Went through that essential anatomy map, GEJ, cardia, fundus, body, incisura, antrum, pylorus, the curvatures. And we really hit on why knowing those spots is so key for you, for understanding reports, understanding the procedure live.
And we mapped out how the endoscopist actually travels through it systematically. The views from the GEJ down, the antrum check, and that critical retroflex view for looking back up. Understanding that sequence really helps you anticipate what's happening, what might be needed next.
Yeah. And we looked at common findings too, from just, mild irritation, maybe from NSAIDs or H. pylori, to defining erosions versus ulcers, and how cancer can look different with a contracted stomach, thick folds, maybe gastric atrophy where the folds just disappear.
And we spent good time on those crucial Sydney protocol biopsies, detailing exactly where each sample goes, antrum A, incisura B, body lesser C, body greater D, and really digging into the why, how that specific mapping is fundamental for assessing the extent of disease and ultimately gauging that future gastric cancer risk. Super important takeaway.
Absolutely. And then we covered handling those high-risk situations like bleeding or vomiting with food, really hammering home being ready with suction, and above all, preventing aspiration, even if it means getting anesthesia involved for intubation.
Safety first, always. And finally, we touched on just how the stomach normally works, that cool sequence of accommodation, then grinding, then slow emptying, and how problems with that lead to things like gastroparesis.
This whole deep dive into Dr. Raju's material, it just underscores how much your understanding of these details really impacts your ability to support the team, predict what's needed, keep the patient safe, especially avoiding aspiration,
Yeah.
and even just understand the significance of the diagnoses and potential risks being discussed. It empowers you in your role.
It really does. And maybe here's a final thought to leave you with, something that really comes through from the source. Think about the real significance packed into those little biopsy jars you handle every day. Jar A from the antrum, B from the incisura, C and D from the body curves. It might seem like just a technical task, labeling and sending them off, but as the source makes so clear, that careful, precise mapping, it's the absolute foundation for the pathologist to figure out how far any precancerous changes, like atrophy or intestinal metaplasia, have actually spread in that specific patient. It's this incredibly direct link between your meticulous work right there in the procedure room and assessing that patient's long-term prognosis, their actual risk of developing gastric cancer down the road. That seemingly small detail, it holds tremendous weight.